Hi, everyone, and welcome to another virtual interview with HCP Live. I'm Kevin Kunzman, Managing Editor. ACC wrapped about a week ago, and with some perspective thoughts and feedback as to how the meeting went, as well as some discussion on one of the biggest trial data points to be discussed at the virtual meeting. Joining us right now is Dr. Paul Armstrong. Dr. Armstrong is a distinguished university professor at the University of Alberta and the chair of the executive committee for the Victoria trial, which assessed vericiguat in high-risk heart failure patients. And Dr. Armstrong is going to give us a little bit of perspective on how exactly the Victoria trial came to be, its most impactful findings, and we're going to talk a little bit about ACC and obviously the current health pandemic that we're facing at hand. So, Dr. Armstrong, how are you doing?
Doing fine, thank you.
Thank you so much for joining us again. It's just a very unique circumstance, and obviously ACC, switching to the virtual format, I think it was really the first to do it that was on our calendar for coverage. So maybe let's start there before we get into Victoria. How exactly did you feel the virtual sessions went as a presenter for it in the late breaker trials?
It was obviously very different, and the social networking that we're used to with 18,000 people due to meet in Chicago was what we were looking forward to. But I think the ACC did a great job in converting it to a virtual program. And but with a large trial like this, we had 42 national leaders from around the world that we were looking forward to spending time with in terms of communicating the results. And so we did a fair amount of virtual preparation before. And of course, we pre-recorded this on the Thursday, and then it went out Saturday morning. So it was a little tricky in terms of the dialogue, but I think they did a great job, and I take my hat off to them, allowing science to actually get out to a broad audience in a timely fashion. So I commend them for making the best of a difficult situation.
Yeah, absolutely. And to your point about probably the greatest lament we heard expressed from people that were planning to attend and present at the meeting was exactly that, the missed opportunity to network and collaborate and just discuss upfront and personally, some of these great findings and where the field of cardiology is going. But obviously a great priority made in the meeting every year is the significant presentation of new trial data and these, practice pushing drugs and how exactly we're, advancing the field annually. And obviously, as part of the Victoria trial, you were part of that this year. Could you tell us a little bit about the findings and the making of the trial itself? What was vericiguat being assessed for?
Well, the first point to make, I think, Kevin, is that the vericiguat is a novel compound. It was fabricated at Bayer some years ago, and it is a soluble guanylate cyclase stimulator. And essentially what that does is it energizes the process, the nitric oxide pathway that's disturbed in heart failure, and stimulates the production of cyclic GMP, which is critical to normal cardiovascular and cardiac function. And so it tackles a pathway in a very different way than previously. We also know that heart failure, which is the kind of heart failure that we studied, is very much high risk. And so we chose a high risk population that had a recent deterioration on excellent standard of care therapy. So this represents an unmet need in a substantial portion of heart failure patients. These were people who had chronic heart failure, reduced ejection fraction, but it had a recent worsening event. And they're at high risk then to cardiovascular death and repeat hospitalization. So new compound, new pathway, and unmet need in high risk population was where we were headed. And we, in this phase 3 trial, based on findings in phase 2, we targeted then this population, randomized them, 5,050 patients in 42 countries to either vericiguat titrated up to a 10 milligram target dose or placebo on very good standard of care. And we then followed them to a pre-specified set of endpoints that were really derived from power calculations where we knew that we needed a number needed to get an endpoint. And so that was the target. We knew we needed 782 deaths actually, and indeed the population over the median period of time of about 11 months, we had about a 37% risk of cardiovascular death or heart failure hospitalization. And we reduced that in a significant way in a 10% relative but absolute 4.2 number of events needed the reduction was 4.2 patient per 100 patient years that we achieved. And that translates into about 24 patients to treat to prevent one primary endpoint of cardiovascular death or heart failure hospitalization. So I think we think a significant result. The side effect profile was really very good. There was a little bit more anemia in the patients with vericiguat, and as we expected, some more hypotension and tendency towards syncope, but modest. And the overall adverse event profile was really quite comparable to the patients in placebo. So in summary, then, we have this high-risk population. We open up a new pathway with vericiguat. It's a once-a-day preparation, no concerns about electrolytes or renal function. That is the case with a number of treatments that are out there, and with a high penetrance of standard-based care. About 14% of them were on sacubitril valsartan or Entresto, and we saw a treatment effect that was pretty significant there as well. We did see an interaction or a suggested difference according to natriuretic peptides. These patients had natriuretic peptides that were about double that of some of the other trials. And there was a suggestion maybe in the upper quartile that there wasn't as much of a treatment effect. So all in all, then, I think a win for heart failure patients, a new therapy, and we're hopeful that this will add value to the complexion of heart failure treatment, and that this drug will be brought forward. Of course, it's an investigational drug, so we look forward to the possibility that it'll be approved and put into play to help this very sick population that represents a substantial portion of people with heart failure. So that's the summary.
Right. Thank you for that. That's excellent. Something that's very interesting about it fitting a role, and we see this particularly in patients that are at high risk or the risk of mortality, just makes for sort of a defeatist mindset for the prescriber in that situation. How does vericiguat, as it's progressing and as we're getting toward a place where we're implementing it in real life strategies, how do you imagine this is going to change the prescribing physician's mindset when they're looking at these high risk heart failure patients?
Well, I think that it'll be a valuable addition. About 90% of these people were on dual standard of care, evidence-based therapy, 60% on triple therapy, and they still failed with this deterioration. 32% of them had devices, either an ICD or a biventricular pacemaker. And we think that when you look epidemiologically, about 1 in 4 patients each year in the chronic stable heart failure, which is the usual place where these drugs are studied, new drugs are studied, we think about 1 in 4 may qualify for this. And as was pointed out very nicely by Lynn Warner-Stevenson, one of the discussants, this is a new population that's being seen. We've made a lot of strides in the advancement of heart failure care, but seeing these patients at high risk come through the gate, I think there is a need for something new, and we think vericiguat nicely fits that bill. And we think it's easy to use once a day, and you don't have to worry about some of the things like electrolyte disturbance. We study patients with very marginal renal function, for example. And so I think all in all, then, a nice fit in a select high-risk population.
Right, of course, we're not talking about a cure-all here. We're not talking about a one.
And not first-line therapy, yeah.
Yeah, exactly. We're talking about something reserved for those extremely susceptible patients. So it's great to see that there's still confidence in even researching that area, let alone prescribing and caring for that range. It gives confidence to the next line of therapeutic research to continue to be ambitious for a condition that, again, it kills about 1/8 of our population, right? So it's great to see a new addition to that. And Dr. Armstrong, in terms of follow-up, where do we go from here?
Well, I think obviously this data and the study report, it was co-sponsored by Merck and Bayer, and so they'll be taking it to the FDA and to the EMA for approval. I think that the question will be, is there more to learn, for example, about the natriuretic peptide story? We have a very rich data set, and we're actively investigating that now in terms of trying to find whether there's a particular window where it may apply around the natriuretic peptide story, for example. We think also that it may well work in patients less sick, but we'll see where that goes. But I think the other thing to say is that this pathway, this cyclic novel cyclic GMP guanylate cyclase stimulator pathway may open other indications in cardiovascular disease. For example, in the area of ischemia, in the area of hypertension, we know that there are vascular effects. We actually don't understand yet what particular mechanism is most likely applying here. And so we have biomarkers that are in the biobank extensively. We have an echo sub-study. So I think from the standpoint of learning and better mechanisms that might point us in one or other direction, we've got some work to do still. And so our committee is active, got a great group of investigators around the world. And so we're very active in pursuing this and hope to bring forward other data soon at other meetings, either virtually or in person, to continue to tell the story.